Yeah. Okay. So, hello and welcome to MedNews Week Keynote Conference, where we aim to bring you the most cutting edge information from medicine's global leaders. I am Rabab Huned and I'll be your host for today. Before we begin, I want to first acknowledge the incredible team that helps to make these events a reality. Our founders are two internationally recognized researchers, Dr. Jan Diefman and Dr. Chandler Park. Our chairs include Dr. Park and Dr. Diefman. Our associate directors include Madhuri, Muskan, Gayatri, and Helena. Our associate managers include Alexandra, William, and Ahmed Aziz. Our educational committee includes Sean, Viviana, Jade, Harshal, Shri Harshita, Saumya, Imad, and Shrivika, and myself. We also want to thank our partners Vomedi and the National Society of High School Scholars, and I3, which is a CME, NCPD, CPE accredited organization with the mission of enhancing the proficiency of the multidisciplinary team by providing evidence-based activities that address unmet educational needs for the healthcare team. Oncology Data Advisor, which is I3's health new website that delivers up to date clinically relevant content, interviews, and commentary from key opinion leaders in oncology. The moderator for today's event is Alexandra. Now, to introduce our keynote speaker, Dr. Anne Stewart. Dr. Anne is the director of the Advanced Fellowship in Hematologic Malignancies, director of the Hematology Oncology Fellowship at the Dana Farber Cancer Institute, recipient of multiple prestigious awards such as the Regional Top Doctor in Castle Connolly and Medical Oncology Educational Award of DFCI. She has more than 160 peer-reviewed publications, abstract, and book chapters in reputed journals such as New England Journal of Medicine, the American Journal of Hematology and Blood. She is an internationally acclaimed speaker with more than 150 keynote presentations all over the world. With that, it is my pleasure to welcome Dr. Anne Stewart. The floor is yours, Doctor.
Thanks very much for the kind introduction. It's really a pleasure to be here and learn about your platform and all the work that you do, which is I've been very impressed by. So my topic today is Hodgkin lymphoma, which is my favorite disease to treat. Here are my disclosures. So as a background, Hodgkin is a rare disease with about 8,800 new cases a year in the US. And this is from the SEER data from the US showing that it is a disease predominantly of adolescents and young adults with a median age of 39. However, it does span across the age spectrum, and we do see patients in their 70s and 80s as well. This is a disease that has a really phenomenal history in terms of improvements in overall survival. And the 5-year relative survival in the most recent iteration of the SEER data is almost 90%. When you look at the distribution of disease across races, you can see it's relatively similar between whites and Hispanic and Black individuals in the US, less common in the Pacific Islanders and Native populations. So one of the things that's really important about Hodgkin lymphoma is the disease affects adolescent and young adults, and these are individuals who have many years of life ahead. So we really have to think very carefully about how we manage these patients. And you can see in patients aged 15 to 19 who are diagnosed with cancer, Hodgkin lymphoma ties for the most common disease seen. And then as the age increases, Hodgkin becomes less common and then significantly less common in adults, given it's a rare disease. So for many years, it wasn't clear what a Reed-Sternberg cell was and what the cell of origin was. This cell was initially described by Sternberg and Reed in 1898 and 1902. They both worked on this. And in the 1990s, there were some very elegant studies done where the Reed-Sternberg cells were micro-dissected off of tissue samples and studied and identified to be actually clonal B cells that had crippled apparatus to make immunoglobulin. They lose the transcription factors, OCT2 and BOB1, predominantly can be helpful in establishing the diagnosis. And we know from looking at histologic specimens that the Reed-Sternberg cells are really the minority of cells in the tissue and live in a mixed inflammatory background. The tissue biopsy is really critical in Hodgkin lymphoma. This is not a disease that should ever be diagnosed using a fine needle aspirate because you absolutely need that architecture in order to subclassify the Hodgkin lymphoma. And the immunophenotype, these cells are, the RS cells are always CD30 positive and typically CD15 negative with DIMPAX5 and CD45 negative. A subset do express EBER. So we know that this is just a really interesting disease in terms of the biology. Again, the Reed-Sternberg cells are rare and they sit in this microenvironment of many different inflammatory cells. And you can see there's just this incredible interplay between the RS cells and these surrounding cells that really drive the growth and survival of the disease. And over the years, there's been a lot of work to identify cell surface markers, including PD-L1, and CD30, which are important in terms of therapeutics, which we'll get to in a bit. So what are the risk factors for Hodgkin lymphoma? We know that EBV plays a role in a subset of Hodgkin lymphoma. This is particularly true in patients who have immune suppression or autoimmune disease. We know that you can see Hodgkin lymphoma in Richter's as a Richter's transformation of CLL, and this is typically driven by EBV. There is a subset of patients, young adults, or children rather, often have mixed cellularity subtype, which can be associated commonly with EBV. HIV is also a risk factor, and the majority of patients with HIV-associated Hodgkin lymphoma also have EBV-driven disease. We know that identical twins actually have a very high risk in the other twin, 100-fold risk, although there is not a lot known about the genes that are responsible for this. So we don't test patients for genetic predisposition syndromes for Hodgkin lymphoma. So in terms of classic Hodgkin lymphoma, this has had a number of different names over time. It was initially Hodgkin disease, and then it became Hodgkin's. Hodgkin's went to Hodgkin lymphoma, classical Hodgkin lymphoma, and now classic Hodgkin lymphoma. There is a rare subtype that I'm not going to cover today, nodular lymphocyte predominant Hodgkin lymphoma, which actually in the most recent classification schema by the ICC is now known as nodular lymphocyte predominant B-cell lymphoma, has a completely different immunophenotype and biology. So classic Hodgkin lymphoma, which comprises 95% of the cases, is subdivided into these four subsets, nodular sclerosis being the most common and the one that we often see in our adolescent and young adult patients with disease in the neck and chest. Mixed cellularity, more common in kids, and older patients can be EBV associated. Lymphocyte rich is relatively rare. Lymphocyte depleted is extremely rare, tends to present with extranodal disease and in immunocompromised individuals, such as patients with HIV. So how do patients present with Hodgkin lymphoma? The majority will have lymphadenopathy in the neck and chest, though the disease can involve any nodal group within the body. It tends to go in a contiguous fashion, so we don't see disease in the neck and chest, and then in the groin without having disease in the abdomen. Fevers and drenching night sweats and unexplained weight loss, the so-called B symptoms, are common, and they don't necessarily reflect the bulk of disease, which is different than in non-Hodgkin lymphoma. Two rare symptoms that are worth knowing about are intense pruritus without a rash until patients excoriate themselves. I've seen a number of patients who this was their presenting symptom, and often you need to do a careful exam of patients who present with intense pruritus for lymph nodes and get a chest x-ray to make sure we're not missing mediastinal disease that may otherwise be clinically silent. And then alcohol-induced pain is extremely rare. I've only seen a handful of patients who have presented with this, but I did see a young guy who presented to his primary saying, I have Hodgkin in this lymph node. Would you please biopsy it because I get pain there when I drink alcohol? That's Dr. Google, but in this case, it was true. So how do we stage Hodgkin lymphoma? We use the Lugano staging system, which is derived from the Ann Arbor staging system, and stage one lymph node or extranodal site, 2 is lymph nodes on one side of the diaphragm, more than one site. Stage 3 is above and below the diaphragm, where the spleen is considered to be a nodal site. And then stage 4 is any presence of extranodal disease. And we do assign A and B, B being the fevers, drenching night sweats, and more than 10% weight loss over the preceding 6 months. This is prognostic in Hodgkin lymphoma and remains part of the Lugano staging system, where B symptoms have not been shown to be a predictor of outcome in non-Hodgkin lymphoma. When we meet a patient with Hodgkin lymphoma, we get baseline laboratory studies, including a sedimentation rate. LDH, again, unlike non-Hodgkin lymphoma, is not often helpful and doesn't necessarily even need to be checked. In patients who have extensive stage 4 disease with bone marrow involvement, the LDH may be elevated. Fortunately, we really don't need to do bone marrow biopsies anymore in the era of PET scans, because we know PET is actually more sensitive at picking up occult disease. If a patient presents with unexplained cytopenias, or occasionally patients will present with bone marrow involvement only, obviously a bone marrow is required in that setting. When we think about, in general, staging, we tend to make a framework of limited or early stage disease, which is stage 1 and 2. Then we think about, is it bulky, meaning is there a greater than 10 centimeter mass, which is typically in Hodgkin in the mediastinum, but it can be elsewhere, or 1/3 the maximal intrathoracic diameter. And then advanced stage would be stage 3 and 4. In Europe and some other parts of the world, stage 2B is often included with advanced stage in some clinical trials, given the worse prognosis than patients who don't have B symptoms. So I think the history of classic Hodgkin lymphoma is really fascinating. It dates back to the 1940s. During World War II, there was a bomb dropped in Bari, Italy, and servicemen and civilians were exposed to nitrogen mustard. And when autopsies were performed on these individuals, it was noted that their bone marrow and lymph nodes had sort of shrunken away, and that knowledge was used to treat patients with lymphoma. And this initially occurred in the late 1940s. And then in the 1960s, MOP chemotherapy was developed at the National Cancer Institute. And in 1970, it was used to lead to the first cure in a patient with lymphoma. And I show here George Canellis, who's been at Dana-Farber for many years and a mentor and someone I have enormous admiration for. And he was part of that original group at the NCI, and I can't imagine what that must have been like. We know MOP has some issues, which we'll get into in a bit. So then ABVD was introduced. The Germans introduced escalated Biacop in the 90s. This is more of an alkylator type regimen we'll also talk about a bit. And then more recently, brentuximab and the PD-1 inhibitors, nivolumab and pembrolizumab, have been approved, and we'll look at some of that data. But really, that's all of this development since the 1940s has led to our 5-year relative survival rates being so high. So what are the various chemotherapy regimens that have been used in Hodgkin? So MOP, I mentioned, was the first. It cured more than half of patients with advanced stage Hodgkin lymphoma. However, it was associated with infertility and stem cell damage that could ultimately lead to myelodysplastic syndrome, or AML. And then ABVD came about and was initially tested in hybrid or alternating regimens and was compared to MOP and found to be superior. ABVD, which is adriamycin or doxorubicin, bleomycin, vinblastine, and dacarbazine, has been used for many years in the US and around the world, has a very low risk of infertility, does not cause damage to stem cells, though it does include bleomycin, which can be problematic, particularly in patients over 60 or those with renal dysfunction. Biacop was devised in Germany, and the German Hodgkin study group really deserves an enormous amount of credit for the work they've done in Hodgkin lymphoma. They run these very large randomized studies that they're able to accrue in rapid succession and really have moved the field enormously forward. So they, after a GCSF was developed, they used this to intensify chemotherapy and use this math modeling to come up with a more intensified regimen. And this has been used in Europe now for years. And we'll show you some of the recent data as I think finally BACOP may be going away. So brentuximab vedotin is an antibody drug conjugate targeted to CD30 with MMAE, a microtubule inhibitor as the payload. This study, this phase 2 study, which led to the approval, the accelerated approval of brentuximab, was really quite remarkable. So these were patients who had been treated with multiple prior lines of therapy and autologous stem cell transplant. And you can see this is really an incredible waterfall plot, particularly in the, in 2011 and 2012 when this data was first presented. The overall response rate was about 75% with a third of patients achieving a complete remission. And although the progression-free survival was relatively short for the whole group, for the patients who achieved a complete remission, some of those patients who had relapsed after auto did not go on to receive allogeneic transplant. And you can see here, some of these patients may be long-term survivors. So this was really a game changer. And then along came pembrolizumab and nivolumab, which for those of you who treat other cancers know these have really been a remarkable success story. And Hodgkin lymphoma really is the poster child for use of these drugs because of the fact that the Reed-Sternberg cell harbors a copy gain and amplification in most cases of chromosome 9p24, which encodes for PDL1 and PDL2. And you can see here in a patient who has amplification, the staining of PDL1 in these large Reed-Sternberg cells is very prominent here. So these agents result in overall response rates of about 70%, though the majority of patients have partial remissions. I'll show you some data. This has really been a remarkable advance in Hodgkin lymphoma. As you know, if you use these agents, they are associated with immune-mediated adverse events. But fortunately, in the studies that we've seen in Hodgkin lymphoma, it's about 5% of patients who require discontinuation of therapy due to toxicity. So with that background going on to think about early stage Hodgkin lymphoma, I thought I'd use a case to illustrate some of the issues. So this was a patient I saw, a 22-year-old woman who actually, her mother had Hodgkin lymphoma and had died of breast cancer after radiotherapy to the chest, which obviously cured her lymphoma. But this is something that sort of guides how we think about patients. So she was feeling well, but had an adenopathy, had a biopsy that showed classic Hodgkin lymphoma. She had a PET scan here that showed disease localized to the neck and chest. This actually looks like it's below the diaphragm, but it's really not. It was a cardiophrenic node. She had no B symptoms. Her sedimentation rate was less than 30. So the issue with, there's a lot of ways to treat early stage Hodgkin lymphoma, and I think it really requires us to look at the individual patient and try to apply the data and patient preference to selecting the best approach. So this data really highlights the issue. So for patients who are treated with Hodgkin lymphoma, the rates of recurrence really are highest in these first few years, and then it really plateaus over time. For patients who receive radiotherapy, the risk of late toxicity, including secondary malignancies and cardiovascular events, continues to rise over time. So again, this is a balance. You really have to look at the patient and their response to therapy. I will say, however, radiotherapy is a very active modality in Hodgkin lymphoma. We have patients who absolutely need it. And now over time, we went from, in the 60s, patients would get a mantle field. And this would be associated with an enormous amount of late toxicity because of all the normal structures that are included here that are radiated. And then we've gone to involved field radiation and now involved site or involved node radiation, and depending on the baseline assessment. And not only are we using much smaller fields, we're using lower doses, and the machines that we use to deliver radiotherapy have also evolved enormously over time. It's going to take a while to see the impact of these advances because the late effects from radiation occur, 10, 20, 30 years down the line. And what are those late effects? So we worry most about secondary cancers. This relates to the area that is radiated. So breast cancer in women who receive radiotherapy under the age of 30, very high risk. This cigarette should be down a little lower here. But for patients who are smokers, there's an increased risk of lung cancer. You can see GI cancers, esophageal cancer in the radiation field if patients have chest irradiation. Sarcomas happen and are devastating, but fortunately quite rare. And you can also see thyroid cancer. Cardiovascular disease is also very important, particularly since we often give doxorubicin. Patients get accelerated coronary disease, valvular disease, aortic valvular disease is often, you can see aortic insufficiency or stenosis. We see a lot of mitral valve disease, pericardial disease, so you can get pericardial constriction, as well as conduction abnormalities. So with all that background, there was a real move now, about 10 years ago. And this work actually had been underway for much longer before this paper was published, looking at can we use PET scanning because we know PET in early stage Hodgkin lymphoma is predictive of outcomes in patients receiving chemotherapy. Can we use that to de-intensify therapy and omit radiation? So this was the EORTC-H10 study and was a very large, well-done study. So they took patients and assigned them to either being favorable or unfavorable, and these are the risk factors. So large mediastinal adenopathy, SED rate greater than or equal to 50 without B symptoms, or 30 with B symptoms, and 3 or more lymph node groups of involvement. Patients were treated with, the control arm was standard despite what the PET showed. So 3 cycles of ABVD plus involved node radiation. For the unfavorable, it was 4 plus radiation. For patients who were in the PET-adapted group, PET-negative patients got 2 more cycles of ABVD if they were favorable, 4 if they were unfavorable, and then patients who were PET-positive got escalated to be a COP and then got radiation. So this was just updated in the JCO, and as you can see here, the definition of a PET, positive PET for this study was Deauville 3 through 5, so that assesses the uptake in the PET scan compared to background uptake. A lot of the more recent studies would consider a positive PET scan just to be Deauville 4 or 5, so it's worth keeping that in mind. About 20% of patients were PET positive. And for those patients who were favorable, if you look at, this is combined modality therapy with 3 cycles of ABVD plus radiation versus 4 cycles of ABVD, you can see there's really a dramatic difference in progression-free survival. And that has increased over time with the 5 and 10-year follow-up. However, when you look at the patients who have unfavorable disease, there is a much smaller difference, and it wasn't actually statistically significant. So to me, what this is telling us is here we omitted radiation in PET-negative patients, but we gave 6 cycles of chemotherapy. Giving 4 cycles of chemotherapy may not be enough in patients with early-stage Hodgkin lymphoma. When we look at the patients who were PET positive, here, you can see that there is a small difference here, but this is now no longer statistically significant. I think the Germans would tell you, you have to start with escalated BA-COP. If you start with ABVD and things aren't going well, and then you switch to escalated BA-COP, you don't get the full benefit, and it may not actually salvage patients. So there have been other studies looking at these PET-adapted approaches with the omission of radiotherapy. This study, the RAPID study, was led by John Radford in England, and it took patients with stage 1 and 2A disease. They got 3 cycles of ABVD. If they were PET negative, and again, this was a Deauville 3 through 5 was the positive. PET negative patients were 1 and 2, and they were randomized to receive observation or radiotherapy. Patients who were PET positive got an additional cycle of ABVD plus radiation. And this study, you can see there's a difference between the two arms. And I think we've always known there's a difference if you omit the radiation, but how much difference are you willing to accept? And this study was a negative study. It did not meet its primary endpoint. Though some people interpreted this study as saying, okay, I can give 3 cycles of ABVD and the outcomes are still pretty good. This is favorable patients. There are no patients with B symptoms included in this group. The Alliance in the US took a different approach and gave 2 cycles of ABVD, and then patients who were PET negative, Deauville 1 through 3, got 2 additional cycles of ABVD. Those who were positive went on to get BIACOP and radiation. And you can see here, the patients who were Deauville 1 and 2 did really quite well with a 3-year PFS of 94%. Patients who were Deauville 3, there was a small number, but they seemed to do a little worse. And patients who were Deauville 4 or 5, even with escalated BIACOP, I would say the outcomes and radiation, the outcomes here are a little bit disappointing. So, I think if you have a patient who has low burden early stage disease and they're Deauville 1 or 2, I think you can justify giving 4 cycles of ABVD. But I generally select those patients carefully. So the Rathel study, which was an important study done again in Europe, where they took patients with unfavorable stage 2 disease and stage 3 and 4, treated with 2 cycles of ABVD. And if they were PET negative, those PET negative patients were randomized to ABVD versus AVD. And there was no difference here. And that's why we often drop the bleomycin in advanced stage patients if they're getting ABVD. And then the PET positive patients got escalated BIACOP. So there were 119 PET2 negative patients with bulky mediastinal disease included in this study. So they got 6 cycles of chemotherapy only. And you can see the 3-year progression-free survival here is really great at almost 92%. So we did a similar approach in the Alliance with bulky stage 1 and 2 patients. And they got 6 cycles of ABVD if they were PET negative, and they got escalated to BIACOP. Here we gave 4 cycles instead of 2, unlike in that EORTC study, which I think made a difference because the overall strategy here, you can see the patients in general did extremely well with 93% PFS at 3 years for the PET negatives and 90% for the PET positives. So moving on, we have brentuximab, we have nivolumab. Can we incorporate these into the therapy of early stage patients? Again, with the goal, I think, of not only improving outcomes, but really trying to limit radiotherapy exposure. And this was a small study led by Jeremy Abramson at MGH. And you can see, these patients did extremely well. This was another strategy where patients started with ABVD and then depending on their response and whether they were favorable or unfavorable, got brentuximab. And you can see for the PET negative patients, these patients did extremely well. This was another strategy by Anita Kumar at MSK. They took patients who had unfavorable or bulky disease, which they defined as 7.5 as opposed to 10. Patients got 4 cycles of brentuximab plus AVD. If they were PET negative at the end, they were treated in 4 sequential cohorts here, 30 gray, 20 gray. This is a 30 gray with a very limited field and no radiation. And you can see there was really no difference between any of the cohorts, and the patients, again, did extremely well. Nivolumab, so the Germans have tended to include radiation in the standard therapy for all of their early stage patients. They did this randomized phase 2 study where they gave either concurrent nivolumab plus AVD or a sequential approach, but all of these patients got 30 gray of radiotherapy. And again, you can see these patients did very, very well. This study was just presented at ASH, asking, can we throw all our best agents, brentuximab plus nivolumab, and doxorubicin and dacarbazine in patients with early stage Hodgkin lymphoma, non-bulky, for 4 cycles, and you can see at 18 months, 97% PFS. This was well tolerated, and the AEs were as expected. So we have a lot of great data incorporating these novel agents. These novel agents are very expensive. They may not be available internationally. So I think this study, which has recently opened, this is a collaboration between the Children's Oncology Group and the adult cooperative groups in the US. And I think this is a really important study. So this is a PET-directed study where patients are assigned favorable or unfavorable based on those risk factors I showed you. They get 2 cycles of ABVD. If they're PET negative and they're favorable, then they get randomized to 4 cycles of chemotherapy versus 4 cycles, 2 of ABVD, then 4 cycles of BV-nivo here. And for patients who are PET positive, they get randomized to BV-nivo plus RT versus escalated BIACOP, followed by RT. The unfavorable is very similar, though the patients in the PET2 negative arm get 4 cycles of AVD. So this is 1,875 patients. There are lots of correlative endpoints, including financial toxicity, quality of life, patient-reported outcomes, and hopefully we're going to have circulating tumor DNA. So this is going to be a really important study, and we look forward to seeing the results. So in summary, for early stage Hodgkin lymphoma, I think the current standard of care remains ABVD. I think using the PET scan to individualize or adapt the use of radiotherapy is sort of how I approach it. And I think a lot of others do approach it, though there's many ways to treat early stage Hodgkin lymphoma. Recent advances include, using these novel agents to reduce even further the use of radiotherapy, and the ongoing trial I just showed you. So what happened to my patient? She got 2 cycles of ABVD, and her interim PET scan was a Deauville 3. So I gave her 4 cycles of AVD, and she remains in remission 5 years later, and now she's working at Dana-Farber. And doing really well. So advanced stage Hodgkin lymphoma. Here is another patient I saw, 59-year-old male who noted lymph nodes in the neck and was having chest pain. He had a CT scan that showed mediastinal and supraclavicular lymphadenopathy with mild splenomegaly. Biopsy showed classic Hodgkin lymphoma. This is his PET scan here. You can see, although his PET, his spleen is a little bit enlarged, it's not significantly avid. We see that a lot in Hodgkin lymphoma. Sometimes it's even mildly avid, but doesn't necessarily reflect disease involvement. But he did have stage 4 disease on the basis of having bony involvement. Oh, sorry. So then we look at his international prognostic score, which I'll show you in a sec. And he had 3 risk factors: male, age, and stage 4 disease. So the German Hodgkin study group initially put together this IPS with risk factors for classic Hodgkin lymphoma, which include low albumin, anemia, male sex, stage 4, age over 44, elevated white count, and lymphopenia. And then they added up these risk factors and looked at freedom from progression and overall survival. And you can see that they correlate nicely here. This was updated in 2012 by the group at British Columbia, which has this really enviable database, and all their patients are treated in a uniform way. So they were able to show that with sort of modern administration of ABVD, the outcomes across the board were significantly higher, particularly in these high-risk groups. And by modern ABVD, one thing to know about giving ABVD is you want to give every 2 weeks on time. You do not delay for neutropenia. These patients don't need growth factors because the risk of febrile neutropenia is less than 1% per cycle. If patients get febrile neutropenia, then you can use a few days of GCSF. If you give a young patient Neulasta, they might not talk to you on the next infusion because they get so much bone pain. It's terrible. So what we typically do is start GCSF day 5 and give 3 or 4 days. And that's usually enough to keep people in range if they've developed febrile neutropenia and we don't feel comfortable treating them without growth factors. So recently, there was a consortium called the Holistic Consortium who put together using an international data set of very large number of patients to look, can we better refine the IPS? And this is a website. You can plug in this information about your patient. And I plugged in my patient here with age. What came out in their assessment was sex, stage, bulk, lymphocyte count, hemoglobin, and albumin. So you can see for my patient, his PFS at 5 years, 70% with overall survival of 86%. I will say that this data does not include patients who were treated with brentuximab or nivolumab. So these numbers are going to come up, but it is a very useful tool. So how do we treat advanced stage Hodgkin lymphoma? In various parts of the world. In the US, we use brentuximab plus AVD typically, and I'll show you that data. In Europe, they tend to use escalated BIACOP using a PET-adapted approach. In pediatrics, this is sort of a US-centric talk. Apologies for that. But in the US, they use brentuximab plus a pediatric chemotherapy regimen called AVEPC. They like to use less anthracyclines because they are very nervous about cardiotoxicity based on experience in treating patients with ALL with anthracyclines back in the day. And in this randomized study that was recently published in the New England Journal, radiotherapy was given to slow early responders or patients who had bulky disease. So what are the outcomes of these approaches with BV-AVD? The 6-year PFS is a little over 80%. The major toxicity that's persistent is neuropathy. When you give brentuximab and vinblastine together, it is tough. Patients have a lot of bony pain and neuropathy, and can be a difficult regimen to get patients through. Escalated BIACOP in Europe. 5-year PFS, really extraordinary, 91%. But again, they're using this alkylator-based regimen. There's a low risk of infertility and stem cell damage. I've gotten criticized for using this slide before because it's really 4 cycles if patients are PET negative. So the risk in that setting is low if patients are PET negative. And then BV-AVEPC is a well-tolerated regimen. However, more than 50% of patients in this study got radiation. So the radiotherapy-related effects to the chest are going to, we need to see how that's going to play out over time. So why do we use BV-AVD in the US? So this was the Echelon-1 study that compared ABVD to BV-AVD. You can see here the primary endpoint in the initial study was this modified progression-free survival, which also included patients who got additional therapy at the end of treatment if they got radiation because it was felt they had persistent disease. That was considered an event, even though they didn't have actual radiographic progression of disease. And there was a modest benefit here. And when you look at across ages, I point out here, if you look at patients who are over 60, there was no benefit at all because patients were not able to tolerate this well. So more recently, last year, at the end of 2022, this was published. So the long-term outcome showed an improvement in overall survival, which was very surprising to many of us. It's a small overall survival benefit of 4.5%. And I think you have to look at this data a little carefully. When you look at the cause of death, there were 11 secondary cancers in ABVD compared to 1 in BV-AVD, which does not make a lot of sense to me. There were some non-Hodgkin lymphoma and other things, but there are very few studies that show any overall survival benefit in Hodgkin because we have such good salvage regimens. So I would take this with a grain of salt. So in those patients, I showed you that data with regard to our elderly patients, not patients over 60 not benefiting in that study. And this is a nice approach that we've used for a long time, where you give 2 cycles of brentuximab, you give up to 6 cycles of AVD, and then BV out back. So you're getting half as many doses of brentuximab. A lot of patients will not tolerate this full course, but this was a phase 2 study with 48 patients. And you can see 28 patients completed all of the therapy. But despite that, the PFS was really quite good. And this is much, much better tolerated than BV-AVD. These are some other regimens that are sometimes used in elderly patients that I just wanted to show for historical purposes, because now we have S1826. So this was data presented by Alex Herrera at ASCO last year. This is a really important study. Again, a collaboration between the Children's Oncology Group and the US and Canadian cooperative groups, randomizing stage 3 and 4 classic Hodgkin 1-to-1 Nivo-AVD, BV-AVD. This included patients over 12 years and older. And these were the baseline characteristics, so nearly 500 patients in each group. And what is really, I think, important about the demographics here is that they are representative of patients that we see in the US. And this is not the case. I think this is because COG was involved. This study actually accrued ahead of schedule, which is unheard of in a cooperative group study. So really representative and inclusive study. The majority of patients had stage 4 disease, and there were a few HIV patients included. So the 1-year PFS, which was a planned analysis, showed an improvement in progression-free survival from 86% with BV-AVD to 94% with Nivo-AVD. And in terms of toxicity, Nivo-AVD was better tolerated. So with BV-AVD, you have to give growth factors because there is a risk of febrile neutropenia and infection. And as I mentioned before, if you give Neulasta with BV-AVD, people feel miserable. So there was a lot of bone pain on this study, which I didn't show in this. And for Nivo-AVD, it was up to the investigator. And you can see even with much less GCSF use, the febrile neutropenia was higher in BV-AVD. Not surprisingly, there was more thyroid dysfunction with nivolumab, much less peripheral neuropathy. Transaminitis was actually higher in BV. And this is what's important here. 11% of patients discontinued Nivo versus 22% discontinued BV. So again, making this point about the race ethnicity inclusion here. In the Echelon 1 study, it's not even reported in the body of the paper. You have to go to the supplemental information to see, and it was not a very representative study. You can see this is the pediatric study, and you can see they do really, really well at getting a diverse group of patients. So at ASH this year, Sarah Rutherford presented the data for elderly patients. It was a relatively small number of patients. You can see about 50 in each group, and that's likely because I did not refer any of my patients over 60 for inclusion in this study, knowing they might be randomized to BV-AVD, which is just not a well-tolerated option. But you can see really a dramatic difference, 93 versus 64% with short follow-up, median of 1 year. There were fewer deaths, though this is not statistically significant. And when you look at the cause of death here, you can see infection and sepsis is what really drove this. So the non-relapse mortality, there was a 10% difference. So the Germans, this is a very important study, the HD21 study. This study uses a Brent. So BRICAT is brentuximab vedotin plus etoposide, cyclophosphamide, doxorubicin, dexamethasone, and dacarbazine. This study randomly assigned patients to BRICAT versus BIACOP. PET2 negative patients got 4 cycles, PET positive got 6. And this was a very well-designed study with co-primary endpoints of superiority of BRICAT with regard to morbidity and non-inferiority for efficacy. So the toxicity was presented at ASH 2022, and you can see that BRICAT was significantly less toxic. And then this was presented at the this should say ICML. So this was a lymphoma meeting in Lugano last year. And you can see here the 3-year PFS is for BRCAT is 95%, which is really with 3-year estimates, longer follow-up than our S1826. So really quite remarkable study with 700 patients, more than 700 patients in each arm. So get ready for some debates. I think we're going to see a lot of debates about which is better, BRCAT or Nivo-AVD. But it's really nice to have both of these very, not everybody can get nivolumab if they have underlying autoimmune disease. So I think this is really advancing the field. So the next question is, well, should we include BV and Nivo? So this was presented at ASH, similar to the early stage study I showed you, with 6 cycles of therapy with AD and 88% 2-year progression-free survival. And again, the toxicity is sort of as you would expect, really quite tolerable. So future directions, can we give less chemotherapy? I think we're probably still going to need some chemotherapy. When you look at PD-1 inhibitors with brentuximab without chemotherapy, which has been tested in elderly patients, the durability of responses is not great. So chemo really works in this disease, but the question is how much do we really need? So there is that ongoing study I showed you of BV-Nivo plus AD. I think we'll probably see a randomized study in the US of Nivo-AVD versus BV-Nivo-AD. And what we really need to figure out again is who really needs these more expensive regimens, because ABVD works really well in a lot of patients, or escalated BIACOP if you're not in the US. So we're hoping that using things like changes in total metabolic tumor volume or circulating tumor DNA, which is coming, will hopefully allow us to select who really needs these expensive therapies. So my patient was treated with BV-AVD. He was under 60. This was not easy, but he did achieve a metabolic complete remission and remains in remission now about 4 years later. So what about relapse or refractory disease? This is a patient I follow who initially presented with stage 2B disease, non-bulky, above the diaphragm. This is not his original PET. He had a PET after 2, which was a Deauville 2. He completed out a raffle approach with ABD, and his PET at the end of therapy showed increasing lymphadenopathy, and he had a repeat biopsy, which showed NS Hodgkin lymphoma. So how are we going to approach this? So, I'll talk about what we use as second-line chemotherapy. In the past, we used sort of combination chemotherapy, relatively toxic combinations, followed by autologous stem cell transplant. We're now using brentuximab and/or PD-1 inhibitors. I think in the future, the question is going to be, do we really need an auto transplant? And what are some novel approaches? So we know that up to 30% of patients will relapse after initial therapy. Obviously, rates are higher in patients with advanced stage disease. These numbers are going to change with the introduction of these better upfront therapies. Rarely we see patients who are primary refractory, and it's really critical in this disease to get a biopsy because these patients can have gray zone lymphomas. Hodgkin patients can develop non-Hodgkin lymphoma. I just got an email about a patient today who was treated for biopsy-proven Hodgkin. Primary refractory biopsy shows diffuse large B-cell lymphoma. So important. Also sarcoid, we see, sarcoid is a risk factor for Hodgkin. So important to get the biopsy. So why do we do stem cell transplant? It's really quite remarkable. It's based on this very small study, 2 very small studies. This, which randomized patients who got DexaBeam salvage chemotherapy with or without transplant. And you can see there is a difference in freedom from treatment failure here. Once this was published, everybody, assumed that autologous stem cell transplant was the answer, as is the case, was the case for the PARMA study and diffuse large B-cell lymphoma. So it was very hard to accrue patients to a non-transplant approach. So that's really been what we've done for years. How do we treat people? So these were, this is sort of standard salvage. This one includes brentuximab and gemcitabine and vinorelbine, and you can see the CR rates, are 50 to 70%. This one is low because it was assessed by CT, and PET really is a better assessment of response. And there's been multiple papers that show having a PET scan that's negative before autologous stem cell transplant is associated with much better outcomes here in the, 75 to 80% or higher range, versus PET positive patients really being much more likely to progress after transplant. So brentuximab, when after it was approved, we started testing it in various second line setting regimen. And you can see here, we see very nice CRs, 70-75%, with good PFS. So this became sort of a standard. The Athera study was a randomized study looking at brentuximab vedotin as maintenance in patients who were high risk. So high risk was determined by having either a primary refractory disease or recurrence within the first year, or having extranodal involvement, and compared. So patients underwent autologous transplant and they were randomly assigned, and you can see there, even with long-term follow-up, there really is a significant PFS advantage to brentuximab, though no overall survival benefit. This, again, it's going to be hard to know how to interpret this data, as many of our patients are getting BV up front. So in this study, we tested brentuximab plus nivolumab as a salvage regimen, given the very good responses in the highly refractory patients. And you can see the PFS curves in patients who went directly to transplant, and in those who were relapsed as opposed to primary refractory, were very, very favorable. And then the most recent data we have for novel salvage regimens is pembrolizumab plus gemcitabine, vinorelbine, and Doxil. This is from Alison Moskowitz at MSK. Patients got 2 cycles, and then if they were in CR, they could go on to get an autologous stem cell transplant. The vast majority of patients had a CR after 2 cycles, 92%. Of the patients who went to transplant, there have been no recurrences. So this is a regimen that we frequently reach for in patients who did not receive any checkpoint inhibitor upfront, so they weren't on the randomized trial. So the PD-1 inhibitors really, in addition to being very active as single agents, they seem to carry some chemosensitization quality to them. And this was a nice analysis from Stanford, where they looked at the outcome of patients undergoing autologous stem cell transplant in the era from 2001 to 2010, and then 2011 to 2022. And you can see that there is a significant benefit, or a significant improvement rather, in outcomes over time. And there are probably lots of reasons for this, including better supportive care and other things. But when they did a multivariable analysis for PFS, they saw the usual things: age, whether you're relapsed or refractory, whether you were in a metabolic CR at the time of transplant. But they also looked at, a small percentage of patients that had a PD-1 inhibitor, but there was a very significant hazard ratio here for improvement in outcome. And this was just shown presented at ASH this year. This was a large retrospective multi-center analysis, and they looked at patients according to what salvage therapy they got prior to autologous transplant. And you can see patients who got a checkpoint inhibitor with or without brentuximab have, really outstanding progression-free survival, whereas patients who are getting chemotherapy only or brentuximab only, they're doing okay, but there does appear to be a very significant difference. And this is certainly what we see in the clinic. So then the question is, do you really need a stem cell transplant? I'll show you some additional data, but I think you probably do, because these patients, we try to minimize treatment and really tailor it upfront to minimize late toxicity. But for patients, that small percentage of patients who are primary refractory or relapse, then I think we really need to treat them aggressively. And if you look at the data for BV/nivo alone in older patients, those do not appear to be durable remissions. Maybe with pembrolizumab plus GVD, or in younger patients, BV/nivo will preclude the need for autologous transplant. But I think we'll need to see that data before we stop doing transplant, which really is a tolerable and very effective regimen or approach in these patients. So what do we do for those patients who are really refractory? So this was an interesting paper. Oh, and I apologize that I don't have the citation here. I think it's Nye from JCO. I think this was published in 2019. So this looked at patients who were, so they gave a PD-1 inhibitor, and then they gave decitabine in combination with a PD-1 inhibitor, and they saw more complete remissions. And then they even treated patients who were PD-1 resistant and treated them with decitabine plus PD-1 inhibitor and could salvage patients. And you can see here there were a significant number of patients who achieved a complete remission. So, and you can see the progression-free survival here of the combination versus monotherapy. And even in those patients who were resistant, did quite well. Toxicity sort of as you would expect, giving decitabine, mostly myelosuppression. So there are a number of new approaches that are under study. This was a poster from ASH looking at targeting PD-1 and TIM3, another checkpoint inhibitor in Hodgkin. This was the phase 1 portion, and you can see there are some responses. These are patients, again, who were refractory to PD-1 inhibitors. This was well tolerated. So then what about adoptive T-cell therapy? CAR T-cell therapy in refractory and relapsed diffuse large B-cell lymphoma has been really a game changer. What about in Hodgkin? So this was a study that was now presented 4 years ago from the group at Baylor, which has done a lot of great work looking at CD30 CAR. And, initially they used various lymphodepleting regimens, and with bendamustine, which one would think would be good at lymphodepletion because it really is tough on your lymphocytes. None of those patients responded. When they gave bendamustine plus fludarabine, which is a relatively toxic combination, they saw better responses, and flu-cy looked reasonable. You can see the PFS here. And then at the Lugano lymphoma meetings last summer, the same group showed their work using donor allogeneic EBV-specific T cells that they transduce a receptor to CD30. And they had treated 16 patients, very highly, the thing about Hodgkin is you can treat people with multiple lines of chemotherapy, and they tend to still respond. And that's why you'll see these patients with very long, many numbers of prior lines of therapy. And you can see the overall response rate was 75%, CR rate was 38%. But these CARs do not persist in the circulation. They, and maybe they're all going to the tumor, which is maybe a good thing. But what you can see here is, patient got infused, had a response, got another infusion, looked good, but then regrew. So then got another infusion. And, if you're having to give lymphodepletion, it's really not feasible to continue to give people repeated lymphodepletion for infectious reasons, as well as, for risk of MDS. So this is another approach. AFM13 is a bispecific molecule that binds to CD16 and CD30. So using NK cells to destroy the RS cells. And here they use donor cord blood derived NK cells. This is work from MD Anderson. And they complex these cells. It's really pretty cool. They complex this bispecific antibody with the NK cells and treated people. They had to get lymphodepletion. And similar sort of story here. Patients had very nice responses, but only 30% were disease-free at 1 year. So, I think this may be a viable strategy, but probably not a curative option, and patients are going to need to go on to additional therapy. So this was a poster shown by Alison Moskowitz at ASH. This is the schema for an ongoing study of AFM13 with these donor-derived allogeneic NK cells. So this drug, camidanlumab tesirine, is a CD25 antibody drug conjugate with a PBD warhead, and is a drug that actually has quite good activity, particularly in patients who achieve a complete remission, which is about a third of patients with an overall response rate of 70%. With median of 6 prior lines of therapy. However, this agent was associated with a risk of Guillain-Barré and polyradiculopathy in about 7% of patients. And it's not clear if this drug is going to move forward, but it was quite active. So the one other thing I wanted to mention was, what about allogeneic transplant? We know that this is potentially curative. A lot of our patients are not excited to go to allo after auto transplant. And in the past, the PFS has been in the 40% range. But there does appear to be an improvement in outcomes in patients who've had prior PD-1 blockade. However, it is associated with an increased risk of GVHD. So to counteract that, post-transplant Cytoxan has been used even in patients who are not getting haplotransplant. And this is the GVHD-free, relapse-free survival here and progression-free survival. And you can see patients are doing much better here. Non-haplo, this is haplo with PT-Cy, this is non-haplo with PT-Cy. And these are the patients who didn't get PT-Cy, who do worse. But these curves look, pretty encouraging, and, may flatten out over time. 200 patients, this is the overall survival. So where are we going next in Hodgkin? This data looking at adding hypomethylating agents to PD-1 inhibitors is intriguing, and there are a number of trials going on in the US looking at this. Can we add other immune checkpoint blockade to PD-1 like LAG3? I didn't show you that data, but that's being done in TIM3. We'll have to see if that's a good strategy. CAR T-cell therapy, I think we were very excited about this initially, but it is unclear that these responses are going to be durable. There will be a CD30, CD3 bispecific antibody that's going to be tested in Hodgkin. I think we'll have to see how that works. This is a very different disease than non-Hodgkin lymphoma because, again, you have very few tumor cells and they're surrounded by all these other inflammatory cells. And that may be why CAR T is not as effective in this setting, but we'll see. And I think we're excited to participate in these studies and then the AFM study. So, unfortunately, at this point, I think allogeneic transplant is the only potentially curative therapy for relapse refractory Hodgkin lymphoma after autologous stem cell transplant. And fortunately, that's a relatively small number of patients, but it is an area of unmet need. So my patient, after he had primary refractory disease, he got brentuximab, he had a PR, and then he got ICE and had a complete remission. He had an auto transplant, but then relapsed 6 months later. He then was treated with pembrolizumab for 7 years. He initially achieved a complete remission, but then developed slowly progressive disease. And all this time he was living his life doing all the stuff he wanted to do. He was not at all interested in an allo transplant. When his disease started to progress, I gave him pembrolizumab plus GVD, and his PET after 2 cycles looked great. I was very excited. But then his disease progressed after cycle 6. So then I thought, well, let's try BV-Nivo. Maybe there's some synergy there. That didn't work. He went on a trial with ipilimumab. That didn't work. And now he's getting bendamustine, which is actually quite a good drug in the refractory setting. But it impacts T cells, so he's not going to be a candidate for a bispecific. He's unlikely to respond to a bispecific antibody study. So I am trying to convince him to go to allotransplant at this point. So with that, I'd like to thank, this is our phenomenal Hodgkin or lymphoma group at Dana-Farber. All of us treat Hodgkin. I'll call out, Margaret Shipp has done a lot of this work, including dissecting out the biology of Hodgkin with the 9p24 story, doing a lot of work on circulating tumor DNA, and of course, George Canellis who still calls into work. He doesn't come into work often, but he's approaching 90, but still, an amazing thinker. So with that, thank you very much.
Thank you so much, Doctor, for that wonderful keynote. And it was truly so educational, and the presentation was really informative. The topic of Hodgkin's lymphomas has always amused me and was quite an eye-opening one. And the way you have explained us and summarized the whole Hodgkin lymphoma is truly awesome, and it has made so easy for like us medical students to understand it. And now for the Q&A section, I would like to pass on the mic to Alexandra.
Thank you so much, Dr. LaCasce, for this wonderful presentation. We're now going to begin the question and answer portion of our session. We've received a lot of questions, but want to be cognizant of your time, so we will do our best to get to as many as we can in the time that we have with you. And so for our first question, I'll actually be passing the mic back to our host, Rabab.
Yeah, so Doctor, my question to you was, how do you foresee the use of artificial intelligence in improving the various aspects of Hodgkin lymphoma patient outcomes?
So, I think AI will probably have a big impact on our ability to look at large data sets. I think one of the things we see over and over and over again, maybe more so in not, an aggressive non-Hodgkin lymphoma, is such a disparity between the outcomes in clinical trials versus what we see in clinical practice. And it's been difficult to sort of harness all of the real world data. So I think that's one way that we'll be seeing, I think an impact of AI. And I think for our scientists who are looking at, circulating tumor DNA and all these things that, I don't fully understand AI and how it's gonna, but I am sure that it's gonna have a big impact, for our computational folks who are looking at, lots of data coming out of experiments and things and helping them to, analyze that data.
Thank you so much, Doctor.
For our next question, we'll go to Dr. Yan.
Thank you so much for that amazing presentation. It was truly a great tour de France of really essentially the textbook of this disease. A question that I had was, you spoke about the promise of next generation of cellular therapies. We've seen tremendous promise with CAR T cells, and now in many ways we're looking at the next frontier, which is NK cells, off-the-shelf CARs, allogeneic CARs. How do you envision the future of treatment and therapeutic approaches to this disease? Do you envision a combination of one or two cellular therapies with chemo and or radiation therapy? Or do you envision the field kind of moving to that next frontier of immunotherapies and that kind of being the framework of care within the next 5-10 years and onward? Thank you so much.
Yeah, I think we're going to need to see, the data for CAR in this disease has been disappointing. We were waiting for, there was a company that was running a study, and we had this list in our workroom, and we were waiting and waiting and waiting. And we had these patients who were, really looking for, because we were so excited about CAR T. And then, the company just shut down the study because the preliminary data didn't look great. And I think it's a very different disease because you got to get through that immune microenvironment. And I think there's a lot of, I think we really need to understand the biology of that microenvironment to figure out how best to use cellular therapy to, is that going to be an option that works in this disease? And I think the NK cells, such a cool work by Katie Rizvani, but, doesn't appear to be very durable. And I think the problem again with CAR is if you're giving people flu-cy over and over and over again, they've had an auto transplant, they're going to get MDS. And we see this. So I'm still a little bit skeptical about CAR in this particular disease. I don't think I've been convinced yet that there's huge promise.
Thank you so much.
Next, I'll be passing the mic to Ed Heath.
All right, so thank you so much for your time and all the information you've shared today. So my next question is, what are your thoughts on the use of epigenetic therapy, and does it hold potential in the context of Hodgkin's lymphoma?
So there have been some studies looking at epigenetic therapies, HDAC inhibitors in Hodgkin in the past that were somewhat successful. I think it may be in combination with other therapies. I think we still have an unmet need, and I think we need to better understand how these agents might work from a biologic perspective before, there have been some attempts to look at epigenetic modifiers, but not a lot yet. And I think when you have these cell surface markers like PD-L1, CD30 that we've been so successful at targeting, I think it's can we add things to those to increase the problem with both of those in the relapse and refractory setting? Now everybody's going to get them up front, so that's going to be a problem. But the complete remission rates are low. They're very active, but the CR rates are low. So we need things like hypomethylating agents. Maybe, that decitabine data is intriguing. So maybe that's going to be another way to bring up those CR rates.
All right, thank you.
Thank you. I'm going to jump in with a question. Towards the beginning of the presentation, you discussed a little bit about how Hodgkin's is most common in younger individuals who have a significant portion of their lives ahead of them. And I would love to hear a little bit more about how age plays into your treatment of these patients.
Yeah, so age plays a huge role in how we select therapies, because if I'm seeing these are my two favorite populations of patients, the AYA patients, the adolescent young adults, and then the really elderly patients. So the elderly patients, your goal is to be less aggressive, to really try to maintain their quality of life, but not do anything that's going to harm them. The young patients, you really want to cure them, but you also got to think about, what is the impact of if we give radiation, where are we radiating? There's been looks at proton. We don't know if proton is better than photon. So you really have to think about a lot of things. And the other thing you have to really think about in these patients, young patients, is the psychosocial impact of undergoing treatment. So this is something that is super important. So, these patients get PTSD. They come into the clinic, and it's very difficult, and it's such a critical time in a young person's life to have cancer and to be, completely different than their colleagues and friends. So, there's a lot of work in putting together AYA programs. We have one, a number of places have one, but I think we really need to work together as a community to figure out how we can best support these patients. And, we want to cure them, but we also don't want to interfere with their ability to have families or, live a full life.
That's really interesting to hear about how you take those factors into consideration. Thank you. I'll now be passing the mic to Madhuri.
First of all, thank you so much for that wonderful presentation, Doctor. I think I learned everything from the beginning to the end of Hodgkin's lymphoma itself. So thank you for that. My question was something related to something I recently read about preclinical models, including patient-derived xenografts and organoid cultures itself. So how can we actually utilize them to kind of understand and screen novel therapeutic agents and kind of help with drug resistance in Hodgkin's lymphoma itself?
So this is very tricky in Hodgkin because cell lines, you need the microenvironment. So having the Reed-Sternberg cell alone is not enough, right? Because it's that interplay that really is critical to the biology of the disease. So, it's been very difficult to develop cell lines or even PDXs to study this. And you really need an intact immune system to be able to assess the impact of these therapies. So it's tough. I mean, I think there are people who are still, obviously working on this, but I'm hoping that circulating tumor DNA is going to be a way that we can really understand this disease. It's amazing for a disease that has so few tumor cells, it sheds a lot of ctDNA. So I've now seen, I think, 7 patients who were with Hodgkin who were picked up on prenatal testing. You know, they do the NIPT testing and come back with this like chaotic report. And that has led, we have some people, Judy Garber at our group, who does total body MRI. And a lot of these patients will have Hodgkin, or I've seen primary mediastinal. So I think we need to harness that, because then we can really see in vivo, as people are getting therapies, what's happening with the circulating tumor DNA. You know, imaging is very important. And I think there'll be some combination of using novel ways of assessing PET scan or other imaging techniques and looking at circulating tumor DNA to help us really, because then you can understand resistance. You know, I think we're going to get a lot of information when that becomes mainstream. It's not there yet, but getting closer.
Thank you. And for our last question, I'm going to pass the mic to Kennedy.
All right, hello. Thank you so much, Doctor, for your wonderful presentation. Yeah, it's been great listening to you tonight. Yeah, so my question for you is, given the present innovation within oncology in terms of precision and targeted diagnostics and therapeutics, how do you envision this being translated to countries with less resources?
That's great question. You know, I think these liquid biopsies, you know, one of my colleagues did some work in Guatemala where they were able to use a very simple technique of gene expression profiling using capillary gel. I forget exactly what the technique was, but they were able to figure out subtype of lymphoma based on this, you know, without having a pathologist, without having a big tumor specimen. And I think that's something that we really need to be able to roll out. And, you know, we really need to partner with our colleagues. There are not oncologists in many parts of Africa and other parts of the world. So I think the onus is on us to team up with people around the globe to try to help you know, bring these technologies low cost and, you know, support the, you know, getting novel drugs much more broadly. Because, you know, even in Canada, you know, I don't think they can give BV-ABD to stage 3 classic Hodgkin lymphoma. You know, they have very, you know, the approval process is very different there. And you can argue, well, if you don't have an overall survival benefit and, you know, this sort of thing, but you know, I think that we really need to work together globally to try to figure out how to bring these advances more broadly.
Yeah, you raised some really great points, and I really appreciate you incorporating that global perspective. That's really interesting for us to hear. So we're going to finish off with one more humanizing question. So for our more junior attendees who are just getting into research and medicine, what inspired you to pursue this field, and how has mentorship played a role?
So that's like my favorite question, because I think mentorship is critical. And the reason that I decided to do lymphoma was when I was a medical student, I had taken 5 years out after college, and I worked in an art gallery, a contemporary art gallery. So I'm very visual. I like looking at, first year of medical school, we had a hematology course, and I just loved looking at slides and the whole thing. And the woman who taught the course was this woman, Jane Deforge, who had been the president of ASH as a woman in the 80s. And she was a Hodgkin lymphoma doc. And from first year of medical school, you know, I want to be like her. I just found her so inspiring because she treated patients, she taught medical students, she did research, you know, and she was just incredible. And then I did some rotations in oncology, and I did a hematopathology. I gave my medical school talk on the Reed Sternberg cell even back then. So it was pretty early that I knew I wanted to do lymphoma. Yeah. But the mentorship was critical. And, you know, I would say reach out to everybody. Likes, you know, people like to mentor. People like to tell their story. People like to, you know, so I'm a program director for our very large HEMONC program. And my favorite job is connecting people. So trying to figure out, what are you interested in? Oh, who do I know that I could introduce you to who can become a mentor? But I think, you know, being deliberate about mentorship is so important. And I'm just glad you're asking that question early, because I think that's how we get people into the field. Is it's, you know, you have to have someone who helps you along the way. It makes all the difference. Yeah.
Definitely. Well, thank you so much for this incredibly informative presentation, Dr. LaCasce. This concludes the question and answer portion of our session today. So another big thank you to Dr. LaCasce and to our audience for all of the great questions, and to all of our attendees. Please continue to follow